Hello, everyone. And I really salute all of you who are sitting here through the long, grueling hours. And ours is the 18th presentation that you are listening to. Thank you very much. I am, in spite of being a dentist, I'm here because of this one person who, explained me the need of broadening my horizons, breaking my tunnel vision. Dr. Sandeep Tamane sir, he is here today, and we work together in Dinanath Mangeshkar Hospital Multi-Speciality Center, and we work together. Thank you very much, sir, for being there and bringing me on this path. And another person, he's not here, but he's my Guruji in geriatric medicine, Dr. O.P. Sharma sir, and I owe him a lot for always encouraging and not letting me feel left out in this broad field of geriatric healthcare. Thank you. So this is something about me. Let me not waste too much time. It's already there. You can, just read the slide. I'm not going to talk about it. This is too elaborate, so I'll skip it. And let's go to our topic. This year, when we were, having our certificate course, which is conducted by Geriatric Society of India, Dr. O.P. Sharma sir insisted that I speak about oral frailty also. Actually, my specialty is prosthodontics, and I don't deal with oral medicine diagnosis and radiology. Frailty belongs over there. But since sir said that, if it's not your topic, read about it, prepare for it, and present it. So there, I started reading about oral frailty, and I would like to present some things about oral frailty in front of you today. And the most important part, oral rehabilitation. Asha, you know my habit to get carried away. Please tell me, remind me for the time, because, you have to go next. So, what is geriatric dentistry? Let me just share very simple things which I have also Googled, but I found them very interesting. It is a specialty in dentistry that involves multidisciplinary approach. In all my presentations, I utter this word at least 50 times. Multidisciplinary approach. Yes, it's important. Yes, we all need to get rid of our tunnel vision and at least know a little bit. I used to tell my father that I'm not going to read about thorax and abdomen and upper limbs and lower limbs. My father asked me, I'm an engineer, I don't understand, but like you're treating a human being, right? How can you not study? Because it's not important, that's not part of dentistry, I used to say then. But I realized today that what my father said was right. We need to know at least a little bit in each field that deals with geriatric healthcare. So you need to know a little bit about dentistry. I need to know a little bit about geriatric medicine, nutrition, physiotherapy, etc. So it is in the evaluation of oral health, diagnosis, prevention, and treatment planning for senior citizens in our country, let's say 60 years and above, dental treatment of elderly and or medically compromised patients, and providing palliative treatment and symptomatic relief from oral health problems, even though I cannot provide that flashy smile and book picture type of a treatment for my patient. At least the patient can have a sigh of relief. The day-to-day life of patient becomes comfortable because of my dental treatment, and I'm happy. My aim is achieved. So situations like mucositis, xerostomia, deep dental caries, pulpitis, and chronic periodontal problems, if I can provide some palliative treatment, symptomatic relief, then the day is made. So I consider myself like a traffic police. Any dentist can be this traffic police in the chaos of geriatric healthcare. Geriatric patients come to us or they are referred to us for removal of teeth, restorative treatment of teeth, or replacement of missing teeth. But being dentists, we have studied a little bit of anatomy, physiology, biochemistry, medicine, surgery, pathology, everything. So we diagnose the existing orodental problems and guide the patients for a complete oral rehabilitation. Yes, we are trained for that, but we also identify the oral manifestations of systemic disorders and guide the patients to the appropriate physician for the treatment. So the role of traffic police is important, isn't it? So let's come to definition of geriatric dentistry. This is not the definition. Of course, if you Google, there are 10,000 definitions, but this I find more appropriate. Geriatric dentistry or gerodontics is the delivery of dental or let's say orofacial care to the older adults involving diagnosis, prevention, and treatment of problems associated with normal aging and age related diseases as part of, again, that golden word, interdisciplinary team with other healthcare professionals. So, I need your help when I'm treating my geriatric patient. Again, classification. There will be, plethora of classifications. There is an article on classifications of elderly population, but I like this one, which is relevant with my field, given by Ettinger and Lyon et al. It is functionally independent elderly. 70% of the patients who are able to go to the dentist by themselves. Frail elderly, 14%, who have some chronic conditions because of which the mobility is impaired, and functionally dependent elderly, 5%, and the rest of them who are either homebound or institutionalized. Some socio-economic aspect of geriatric dentistry. Financial problems always there, because whatever it is our previous generations have earned, keeping in mind education of their children, they have to have a small house, they have to make investment for their children's marriage, etc. So by the time they reach the age where the health problems start cropping up, they already are tight on their finances. Older individuals in socio-economic strata, if financial constraints are already there in higher middle class or middle class, think about what happens in the low socio-economic strata. Think about the primary caregivers of the dependent, disabled, or vulnerable relatives. That primary caregiver is taking care of the family, earning for the children, their education, the health of himself or herself and the spouse, and obviously then last comes the elderly person in the family. Increase in the per capita cost of healthcare, and those people who are dependent on social or government healthcare system, they cannot afford the dental treatment. Let's make a statement that dental treatment at times can be expensive. It's not only abroad, but over here also. So some patients have to be in the queue, have to be on the waiting list for 6 months to 1 year to just get the complete dentures also. So these are various aspects I want you all to think about. So what's frailty? I'm not the person who should be speaking about it, but since this is relevant with oral frailty that I'm going to talk about, so it's a medical condition of reduced function and health in older individuals. It's degradation from being healthy to being bedridden. Weight loss, exhaustion, slow gait speed, weak grip strength, and no regular exercise could be some of the signs and symptoms. So decreased strength and power, decreased energy consumption, decreased dietary intake, malnutrition, sarcopenia, and the cycle continues. You people are aware of it. Let's come to oral frailty now. So it is advocated by Ijima et al. So the first stage is Risk of the tooth loss because of either periodontitis, meaning surrounding structure of the tooth, the gums and the supporting bone, and dental caries, the decay of the teeth, decrease in oral literacy, awareness, decrease in motivation. Like, we have that motivation. I need to look good. My breath has to be fresh. I need to take care of my teeth. That basic motivation slowly gets lost. Depression sets in, and reduced social activity at the physical and economical level. There are setbacks. Because of that, all these things start rolling. Then there is reduction of speaking, reduction of activity and performance, spilling of food whilst eating, mild choking. Sometimes the patient's primary caregiver says that, doctor, the patient has difficulty in eating. So these days we have started asking the primary caregiver, difficulty at what stage? Whether it is, the patient is spilling food, whether the patient cannot masticate, that is, the patient cannot chew the food, or patient cannot do deglutition properly, whether, there is choking, there is reduced chewing, or there is low appetite or low food diversity. So just think, because of the oral frailty, we have started thinking more what exactly could be, at what level the disability is. Then there is reduction of biting force, reduction of the tongue movement, reduced dietary intake because of that. Once one patient told me, doctor, I get tired while eating. I cannot, I just that sight of food, that I have to finish that whole plate, that makes me feel very scared. So imagine that, we love food, isn't it? The thought of food, like we are standing in between the dinner and you, but those people say that we are tired of eating. Just think about this. Sarcopenia at all levels, locomotive syndrome, undernourishment, decrease in the overall metabolism. Fourth stage, dysphagia, masticatory dysfunction, increased frailty, nursing care needs where the patient now becomes dependent, movement disorders, the patient's movements are restricted, and malnutrition. There are two things I need not, this is again not my area, but because I have started, understanding more about it from various sources. Malnutrition and undernutrition, two different things. Food may be available for the patient, but the essential nutrients are not going inside the system. So, oral hypofunction, Dr. Yoshifumi Toyoshita, Healthcare Science Universities of Hokkaido, he gave a very beautiful presentation on oral hypofunction. It is a multifaceted, complicated phenomena in which the patient has a hypoactive mouth function. It affects the patient's oral functioning, aging problems, disease process, and social environment. So, this one thing affects the entire well being of the patient. The cause and effect relationship, dental caries, periodontitis, denture related problems, dry mouth xerostomia, weak mucosa, which is very prone to inflammation, ulceration, etc. Root exposure, for which Asha is going to speak more in details, and sensitivity, disused atrophy, poor nutrition affecting the whole body functioning, and to add to that, as Tamane sir was explaining in the morning, the pharmacological problems, the polypharmacy. So age takes its toll, and oral environment is not an exception. There are changes on the tissue level, teeth, the periodontium, which is composed of bone, periodontal ligament, and the oral mucous membrane, and the functional changes like decreased salivation, taste sensation is affected, deglutition is affected, mastication is affected. So basically, as I said, there are two issues, as we can see here. loss of the tooth structure, that is one, and loss of the supporting structure, that is number two. Some important things I would just like to highlight in, because we are running short of time. The problems which we encounter, or the problems for which you people send the patients to us: dental caries, xerostomia, missing and or mutilated teeth leading to masticatory inefficiency, periodontal problems like degenerative problems of the supporting structures, attrition and abrasion of the teeth, loss or an alteration of taste sensation, recurrent mucositis, and residual ridge resorption. That is, after extraction, whatever bone remains, it starts slowly resorbing. So at some point of time, making simple, complete dentures also becomes very difficult. So loss of multiple teeth causing aesthetic and functional problems, poor health status of the remaining teeth. We have in our community dentistry DMFT index, decayed missing filled teeth, and DMFS index, decayed missing filled surfaces of the teeth. So in all these things we can evaluate the patient's oral health status. Increased requirement of the dental treatment because of the increased dental problems, degenerative changes in the oral and perioral tissues like oral mucous membrane and gums. What happens? एक दांत गया तो क्या फर्क पड़ता है? What happens if one tooth is extracted? We have to sometimes explain not only the patient but the primary caregiver, because sometimes that primary caregiver is bearing all the charges, that not only the antagonist tooth but the adjacent teeth also get affected, and slowly the entire oral apparatus, the masticatory apparatus, gets affected. That's why that replacement of that one single tooth is also very, very important. Whether there is a direct correlation between the TMD, temporomandibular joint dysfunction or disorder, and the loss of teeth, but again, evidence-based dentistry in our hospital status, because I run majoritarily a geriatric dental OPD, there are so many patients who get better symptomatically after their occlusion, that is the stable bilateral contact of upper and lower teeth. Once that is established, the temporomandibular joint dysfunction, pain, or distress slowly reduces or disappears. So the tooth loss overall is the modifier of the normal physiology. So, because of the tooth loss, there is increased residual ridge resorption, jawbone loss, and overall the facial height. I would like to draw your attention to these three pictures. See the change in the profile. So the protrusion of the mandibular, lip, and chin gives that aged look on the patient's face. So the impaired chewing efficiency and performance, as I said, patients get tired of eating. That results in malnutrition. Thickness of the masseter muscle decreases in the edentulous patients, thus decreasing the bite force. This could reduce the desire to bite, to chew, to swallow, and this could lead to wrong food choices. I'm not saying soft food choices here, wrong food choices, because the patient eats something which is easy to gulp down. And what is easier to gulp down than, carbohydrates? So a patient who is already diabetic, imagine he starts eating suji ka halwa every day. What's going to happen? Or the patient starts going to eat only carbs, even in a very good, well-to-do family. What's going to happen? It's going to lead to malnutrition, or existing comorbidity is going to get worsened. The tooth loss may induce oral dyskinesia. You must have seen the patients who do not wear dentures. Their mandible keeps shaking like this. So, defined as abnormal, involuntary, patterned, or stereotyped and purposeless orofacial movements, patients have no control on it. Sometimes they become very conscious, and sometimes that becomes the reason of avoiding the social contacts. And patient emotionally also gets detached. So the edentulous people may avoid participation in social activities because they are embarrassed to speak, they are embarrassed to smile or eat in public, leading to isolation and depression. So think where the dental problem has taken the patient. So, as Dr. George was saying, we have several specialities except for pediatric dentistry and orthodontics. Everything else is related to geriatric dentistry. So, mainly clinically important specialties could be preventive treatment, oral surgical treatment, periodontal treatment, restorative and endodontic treatment, which Asha is going to speak about, prosthodontic treatment. I am a prosthodontist. I deal with replacement of teeth and missing part of the jaw, palate, etc. Oral hygiene maintenance. Preventive treatment and oral hygiene maintenance is common to all branches and it's extremely important. So, prevention of oral diseases, why? We say that we are a developing countries, we cannot afford this, we cannot afford expensive dental treatment. Then what to do? Avoid, stop the disease from occurring, right? So, prevention, primary prevention is most important because that's the easiest way. We'll prevent the disease so that the patients don't have to spend on expensive dental treatments. So, sorry. Educate your geriatric patient and the accompanying person. Very important, because sometimes, you give them instructions. Most of the times, the wrong way of doing is giving verbal instructions. Always write down your instructions. So you have to give those instructions not only to the patient, but the primary caregiver also, maybe a relative, a friend, caretaker, anybody, about preventive dental care and existing treatment needs. Promote good oral hygiene habits, motivate to practice oral hygiene maintenance, and effective follow-up. Recall, and recall is the key to avoid complicated dental diseases. So, I came across this Epicity Mobile Dental Care, some leaflets that were there for education. They were very helpful. You can also visit their website. When to get help? As physicians, as paramedics, as nutritionists, or as physiotherapists, you can help the patient. You can lead the patients to us in case they need us. When they have bad breath, when they have loose or mobile teeth, when they have stains on their teeth, they haven't got dental cleaning done, that is the scaling or oral prophylaxis as we call it in the past year. If they have pain of any type, the Indian patients are extremely tolerant. When it becomes absolutely unbearable, only then they will report to the doctor, any doctor and dentist in my particular field. Any kind of discomfort, irritation, or ulceration, and loose, ill fitting dentures. The causative agents of oral cancer, right? So, ill fitting dentures are one of the common causes of oral cancer. So, if the patient experiences the following signs and symptoms, they should get in touch with the dentist. Dentures which are over 5 years old. Dentures are not there to last for lifetime because dentures are made up of plastic. They are polymers, they get dirty, they harbor bacteria and fungi. So the patient needs to get rid of the denture. Even if the denture, so to say, is in a good condition, if it's over 5-year-old, it has to be discarded. If the patient is having to use denture adhesives, that means the denture is not fitting. Cracked or broken dentures, they need to be repaired or they have to be redone ASAP, because the cracked portion or the broken portion may again lead to ulceration, constant ulceration, leading to premalignant lesion or oral cancer. If the patient is not wearing dentures for some reason, find out the reason why. Difficulty in chewing, eating, or swallowing, as we discussed, which stage the patient is finding the difficulty in eating food, and not comfortable with the appearance of the teeth. Dentures are made sometimes and patients are unhappy If they are unhappy, either they will not wear the dentures, or they will wear the dentures and cover their face all the time, or they will avoid socializing. We do not desire this. So they need to see a dentist in that situation, and you people will help them in taking help of the dentist in these situations. So to maintain good oral health, patient must get a checkup done every 6 months and get an oral prophylaxis done. That's mandatory. Topical fluoride applications can be a very good preventive dental treatment which will avoid formation of fresh dental decay. Regular checkup visits can identify and prevent any other oral lesion. It doesn't have to be just dental decay. It could be a red and white lesion, pre-malignant lesion, or beginning of the oral cancer. Regular dental cleaning will help maintain the health of the teeth and gingiva, preventing caries, gingivitis, periodontal complications, loose or mobile teeth, and tooth loss. We are born in a culture where we were not taught how to brush. We were taught when we came in, dentistry, we were taught various brushing techniques. What is done is generally some adult, when you are a child, somebody gives you a brush and says, now you have, grown up, just start brushing your teeth. But how? Nobody tells you how to brush your teeth. So there are various techniques. It's, just go to the dentist and learn how to brush the teeth, or, it's time to refresh your skills of brushing. For the geriatric patients, electric or battery operated brushes, especially those who don't have a good grip, they they cannot, they don't have that manual dexterity, for them electric or battery operated brushes help. They're good for patients with, as I said, they don't have a good grip, then they can use it. Tennis ball brush, a modification in which the patient can actually insert the brush in a used tennis ball, hold the tennis ball, becomes relatively easy, and brush the teeth. That is possible. Toothbrushes with soft, extra soft bristles which will not harm the delicate oral mucosa or gingiva of the patient. It is less irritating to the gingival tissues. Toothpastes, again, the best toothpaste, I think, this is my opinion, fluoride is the best, because this is your daily regimen. This is not only for geriatric patients, but this is for all of you all. But as I said, more than what toothpaste you are using, it is the brushing technique that is very, very important. In case of sensitive teeth, this happens a lot with aging. The teeth become sensitive. The hypersensitivity sets in. So for that, specially formulated desensitizing toothpastes are available in the market, and they should be prescribed. Interdental hygiene care, again, nobody taught us brushing, and nobody told us that interdental hygiene is very, very important. So we need to demonstrate flossing. We need to demonstrate the interdental brushing to the patients to keep the interdental area clean. Rinsing. When patients say, which mouthwash should I use? I said, the mouthwash which is the cheapest. Which is that one, doctor? I said, water. Clean water. So the patient should rinse often. Patient should drink water often, which is otherwise also good for geriatric patients. Sip water regularly. Even if it's not possible to go and rinse, just with drinking water after even tea and coffee, take water, swish it around in the mouth and gulp down. Drinking water, that itself is a good habit, prevents a lot of dental complications later. Fluoride mouthwashes reduce the cavities, but those have to be prescribed by the dentist, not otherwise. Antibiotic and antiseptic mouthwashes, again, if required, only then to be used. That is also at the discretion of the dentist. As I said, rinsing mouth with water is the cheapest and the best thing to prevent any oral disease, especially in geriatric patients, because it's very simple. So I'm just going to brush up because these are not my specialties and we are running out of time. We have oral surgical treatments like extraction of multiple mutilated teeth, Pre-prosthetic surgeries, meaning before construction of dentures or any other prosthesis, we have alveolectomy, alveoloplasty, surgical removal of mandibular palatal tori. You are all aware of that. Labial and buccal freenectomy, the freenae, the tissues which become very fibrous and insertion of denture becomes difficult. Then that is done by our oral surgeon friends. Surgical removal of troublesome bony undercuts and flabby oral tissues, surgical extractions of impacted third molars. Some of you have taken that dreadful experience of removal of third molars, and surgical excision of cysts and tumors of the oral cavity, which is, yes, it is done by the oral surgeons. Periodontal treatment, as I said, treatment of the supporting tissues. Oral prophylaxis, that is regular scaling or cleaning of the teeth. Subgingival curettage, removal of dirt or debris or plaque that is sitting tight around the teeth. Periodontal flap surgery, wherein you raise a tissue flap, clean up the underlying tissue and close the flap back. Bone grafting procedures, splinting of periodontally affected teeth. Splint the teeth the way you splint a fracture. Same way you splint the mobile teeth and increase their longevity for some time, give a respite to the patient. Now my domain, prosthodontics. So simple removable dentures, they serve very well in a geriatric patients. Of course, I'm not saying that implantology is not the way, but simple dentures in a normal Indian setup can be easily afforded by the patient. Conventional complete dentures, people say that they are going out of fashion. Well, they may go out of fashion, but they are the need of the time. So they are a need for the patient to maintain the nutrition. Conventional and implant supported fixed prosthesis, either as you call it crown and bridge, or caps on the teeth, the bridge on the teeth, or implant supported prosthesis. Only word of caution is respect the aging and compromise natural tooth structure. This particular thing that this lady has a full mouth bridge, it may be looking all white and nice, but there are hardly any supporting teeth. And believe you me, this bridge is going to collapse in some time. I don't know how many days, weeks, or months it's going to last. And it is antagonized by a poor resorbed residual ridge. So when we do the treatment planning, we also need to apply our mind, and we have to do a treatment with thought of future. So some implant supported prosthesis. Now this particular patient, hastily implants were placed, but the patient had some pancreatic disorder. The patient has fulminating diabetes. The patient is already having antihypertensives. The patient's overall condition is not good. Then why do we put implants? This is the disparity. The dentist must not have gone to the physician, or at least, had a conversation with the physician whether the patient's condition is good to receive complicated dental treatment. Like, as I was giving examples, if I have any doubt, I never hesitate to send a patient to Tamane sir to assess whether the patient can undergo a complicated dental treatment or no. So systemic disorders, vitamin deficiencies, ongoing medications, Beer's criteria that sir has already discussed, anti-resorptive drugs, bisphosphonates, selective estrogen receptor modulators, denosumab, HRT, and calcitonin. We need to dig out the history from the patient. And sometimes when we don't know, it's our moral responsibility to reach out to the patient's physician. So a simple denture can also work in closure of an oroentral fistula. Obturators, when there is some complex surgery has been done for the palate, patient is unable to gulp the food, cannot chew the food, a simple obturator, palatal obturator, can help the patient and improve the quality of life immensely. Come COVID, and we had a tsunami of these patients coming to us, mucormycosis. And the patient, that patient could not talk. He just wrote down, "Doctor, I want to eat and drink." So a simple prosthesis here again, made in 1 day's time. This is a removable prosthesis. The patient had tears of joy because the patient could drink a cup of tea. Patient could drink a glass of water and that Ryle's tube could be removed. So such simple things, they look simple, they are of course complicated, but simple things in the sense of material and technology, we can simplify the patient's life, improve the quality of life. Guide plane prosthesis, post-oncosurgical guide plane prosthesis for the patients. And oral hygiene maintenance. If the patients have bridges, crowns, implants, any complicated thing done in their mouth, we have to teach the patients to clean the complicated prosthesis and keep it in a hygienic condition. And interdental brushes are immensely helpful over there. Keeping the dentures clean. When we give the patient the dentures, we just don't have to push the patient away saying that, okay, denture ka kaam ho gaya hai, like, now you can go. Not like that. We have to write down again the instructions and teach the patient how to keep the dentures clean and make them last at least for 5 years, at least. So it's not that oral cavity and that single tooth or, some dental treatment. Sometimes I get very disheartened when I hear such remarks from our physician colleagues. But it is always taught to us that it is not just that hole in the mouth, but it's the whole treatment, the whole patient. So complete rehabilitation, not just the oral cavity, functional, social, psychological well-being. Let's come together for this, all of us, and provide a comprehensive care, an all-encompassing care to the patient to have maybe not perfect health, but make the day-to-day life simple and healthy. Thank you very much.